Welcome to the Rings a Bell podcast, a pharmacy continuing education podcast for busy pharmacy professionals. My name is Kim Callio. I'm your host. I've been out of the dispensary for about 3 years with having a family and dealing with all the household stuff. And I have not an insignificant amount of anxiety about losing all of my clinical skills. In order to future proof my career, I've decided to start this podcast where I bring on people who are at the top of their knowledge game and I get them to quiz me. And I just deal with the embarrassment because it's better than letting my clinical skills fall into the abyss. But Kim, couldn't you just read a little bit of clinical material every once in a while and therefore keep up with things? Ha 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 ha. That is so funny you mentioned that. I actually spent money I didn't need to spend on a brand new copy of the paper version of Therapeutic Choices when I graduated, thinking I'll just read a chapter every night for a year and I'll know all the things and I'll be so up to date. And I have now unbound it and recycled it. So, truly, a podcast and embarrassing myself on a national scale is the only way I will keep up and or remember things that I used to know well. So, here we are. Welcome. I'm happy to have you here. Without further ado, here is your episode. Hello, welcome. I'm here with Cheen-Young Liu, who is a pharmacy student from U of T, and she has agreed to come on the podcast and roast me today. Welcome, Cheen-Young.
Thank you so much for having me, Kimberly. I think this is an amazing project that you're doing, not only for yourself, but also for students. So I'm really excited to be here.
Excellent. Well, I'm excited to be here with you, and I'm looking forward to upping my skills on the topic of contraception. Before we
Mm-hmm.
start, though, let's get some information about you. So
Mm-hmm.
you're at U of T,
Mm-hmm.
and what year of school are you in?
So I'm about to start my third year of pharmacy at U of T. I did do 2 years of my undergrad at Western University, which is in London, Ontario. And after that, I did some research, some learning, and I figured that the PharmD is what interested me. So I'm here in downtown now.
Wow. Okay. So you're in the PharmD program, and what was your undergrad in when you did a couple of years?
It was a Bachelor's of Medical Sciences, which is just a fancy way of saying life sciences with some healthcare application.
Okay. Gotcha. Yeah. When I went to Queen's, they had a program that was similar.
Mm-hmm.
I think it was just called Life
Mm-hmm.
Sciences, and it was
Yeah.
it was sort of a way of saying these are all the people who want to be doctors, and
Yes, exactly.
and or et cetera, et cetera. Okay.
Mm-hmm.
And how are you feeling about what you want to do for your pharmacy career? Are you looking into community or hospital?
I think when I went into my PharmD, I thought I was going to be in community practice. I had worked in community pharmacy before, and I really enjoyed that experience. However, as I've experienced more in school as well as my other rotations, I'm finding that there's so much more to being a pharmacist than I had ever known coming into this career. So now I'm finding that there are aspects of community, institutional, as well as industry that are really calling to me. So my goal right now is just to explore as much as I can, see what's out there, and hopefully in the next 2 years, I can figure out what I want to be doing.
Excellent. I would agree. Certainly, there already were a lot of careers out there for pharmacists, but it seems like in the last 10 years, it's really exploded. The different
Mm-hmm.
options. I mean, I don't think I would have been considering podcasting when I graduated. Well,
Mm-hmm.
I've been told I have a big mouth for a long time, but not necessarily that that could be a career option.
Mm-hmm.
And you've created a contraceptive quiz for me today.
Mm-hmm. That's
How,
right.
how did that feel being on the other end of quiz making versus quiz taking?
Well, it's a little bit intimidating, to be honest. I did choose this topic because I think it's something very important to touch on. I believe that women's health, and when I say women's health, I also include people who were assigned female at birth or have female anatomy, anybody who could be impacted by pregnancy, basically. I feel like that women's health is just not given the attention it deserves, especially considering that, 50% of the world is female. And I believe that contraceptives and family planning is such an important tool for women to empower women and for women to take control of their lives and their own choices, which is something I feel very passionate about. And I also thought about how when I worked in community pharmacy, there were so many birth control prescriptions coming in. So I think that this would be a very interesting topic to discuss from a community pharmacy point of view.
Absolutely. And it's quite topical now in BC because we,
Hmm.
as pharmacists here, have the ability to prescribe contraceptives.
Hmm.
So, um, yeah, really haven't been keeping up with all that that entails, but I know,
Hmm.
having a clinical knowledge of all the different contraceptives and the options is kind of the first step. And then you layer on all the regulatory stuff after that.
Hmm.
Okay.
Hmm.
Well, I'm excited to get started.
All right. Okay. So with my questions, I think I'm going to start a little bit easier and then we'll gradually get into it.
Oh,
A
God.
few of these.
When you say when you say you're starting easier, my fear is that it's gonna be easy and I'm gonna still do poorly.
Oh, it's
Pray
okay.
for me.
I had to relearn a lot of the stuff for myself as well. So it's a learning opportunity for all of us.
Okay. Well, that makes me feel better.
Hmm. Right. And most of these are relatively open-ended. I do have a few points that I want to touch on with each, but there's sometimes no wrong answers. Well, some wrong answers, but multiple right answers, we could say.
Okay. All right. Let's do this. And don't
Hmm.
hold back on this, right? You are the one at
Okay.
the top of your knowledge game. I am the female in my life who intentionally did not use contraception and has a 2-year-old and is now and is now sitting here realizing that, oh, there are a lot of implications. I can't spend as much time in the dispensary as perhaps I need to keep my clinical skills up. Therefore, I need you to whip me back into shape.
And as I was making these questions, I was thinking that maybe Kimberly would have some personal experience. Maybe that would help with these questions.
Mm,
So, extra points for
okay.
you.
Extra points. Perfect. All right.
Okay. Our first question. Combined oral contraceptives, or COCs, are a common choice of contraception in Canada as well as many parts of the world. What are the components of COCs and what are their mechanisms of action?
Okay. So we have um, ethinyl estradiol is the
Hmm.
estrogen component, and it is suppressing ovulation
Hmm.
at the pituitary? Question mark. I
Hmm.
don't know if that's right, but yeah. So the estrogen on board is suppressing ovulation, and then you
Hmm.
have a progestin component related to progesterone, which is helping to prevent cancers of the uterus.
Mm, yeah, that is a pretty good answer. So, as you said, there is a synthetic estrogen and a progestin. The estrogen most commonly is the ethinyl estradiol, and the progestin, some of the common ones could be, for example, norepinephrine. To put it very briefly, together, these high levels of synthetic hormones cause the body to believe that you're pregnant, then inhibiting ovulation and preventing pregnancy. The elevated levels will create a negative feedback loop to the hypothalamus and the pituitary. So ultimately, it leads to suppressed luteinizing hormone and follicle stimulating hormone, which then would inhibit ovulation and follicular development. And for the progestin, it also helps to thicken the cervical mucus as another method of preventing pregnancy.
Okay, sweet. That was a great refresher.
Hmm
So it is, as I was giving the answer, in my head I'm going, it's pretending that you're pregnant. And then I thought, did I make that up? Okay, but I didn't make that up. So
hmm
you are mimicking pregnancy with
hmm
both the estrogen component and the progestin component.
hmm
And then that plus the cervical mucus thickening in the progestin component. And
hmm
that is feeding back on the hypothalamus and the pituitary.
That's correct.
Got it. Okay, sweet.
hmm One question down. Okay, this next one. Which of the following are absolute contraindications of COCs? This one, I think I'll read you a few and or we can go one at a time. That might be a bit easier. So,
Sure.
firstly, being 8 weeks postpartum and breastfeeding.
For combined,
COCs.
I'm going to say that's an absolute contraindication.
That's very close. It's actually technically 6 weeks. And that is because of the elevated clotting risk, as well as estrogen does impact milk supply and the quality. At 8 weeks postpartum, it's not the absolute contraindication, but they would still advise that you wait a little bit longer if you could, just to be on the safer side.
Okay, so the combined oral contraceptives postpartum up until 6 weeks postpartum are a absolute contraindication because you're
hmm
tacking estrogen onto an already pretty high estrogen state. Is that the deal?
Yeah, so the 6 weeks postpartum, you're already at an elevated risk of blood clots. And
Got
then,
it.
as we know, estrogen would increase that risk. So we just want to play it safe in that time period.
Okay, got it. And then if you're breastfeeding and you're concerned about um, breastfeeding quality, you would probably opt beyond that not to do a combined oral contraceptive. You'd go with a progesterone only, but
hmm
it would be not an absolute contraindication.
That's correct.
Got it.
hmm
Okay. Okay.
Our second one, smokers who are 35 years and older and who smoke 15 or more cigarettes a day.
This better not be another trick question because I'm going absolute contraindication on that.
That's correct. So, all these factors together will increase the risk of cardiac events such as MIs. And I guess an add on question, what if they were 35 plus but less than 15 cigarettes a day?
Relative contraindication?
So, it's still a contraindication, but not as absolute. In this case, they usually say as long as the benefits outweigh the risks. However, there's very, very few situations where that could occur. So, it's essentially a contraindication.
Got it. And so if we're
hmm
looking at trying to find a person, well, maybe I shouldn't go down this path because you might have this in parts of the rest of your question. I'll reserve my questions to you for after the rest of these.
Sounds good. And what about breast cancer, current or past history?
I think that would be a I think current would be an absolute contraindication. Past
hmm
might be a if risk outweigh benefit situation.
So it is a contraindication for both, as estrogen can stimulate the cancer cells in some types of cancers. However, this is a little bit controversial. There is some data showing that the risk is there, but it is deemed rather low, similar to the risk of obesity, low physical exercise. So there is a risk, but not as high as people would think. And there's
Right.
also another factor where the risk of breast cancer is higher if you don't have a child before you
Right.
are 25 years old. And some people are suggesting that, well, those who are taking COCs are preventing or delaying pregnancy, maybe rather than the COC is linked with the higher breast cancer rates, it could just be not having a child before the age of 25.
Right, you've gotta parse that
Hmm.
data out a little bit better. Yeah, I'm
Yeah,
just thinking
so
in terms of, hormone replacement therapy. I've had a few
mhm.
patients who were taking estrogen hormone replacement therapy, and they had a past medical history of breast cancer, and it was sort of a shared decision with the doctor. It seemed worth it to them to deal with the hot flashes and whatnot.
Mhm. Yeah, and I know, though this is not our topic today, for HRT, it's usually topical or transdermal applications, and I believe
Mhm.
that there is a different risk factor compared to just COCs orally.
Got it. Yeah.
Mhm.
Perhaps a topic for another day.
Mhm. Mayhaps. All right. And what about a personal history of VTE or stroke?
I'm gonna say absolute contraindication.
Yeah, very straightforward. The next one is diabetes.
Fine.
This is also a little bit of a trick question. My
Oh,
apologies.
come on.
It is fine. It's fine as long as the patient doesn't have any microvascular complications.
Okay.
Hmm.
So as long as you don't have any, kidney issues or issues with your vision,
Yeah.
then
So
those would be
making
signs that
sure.
you've been rocking diabetes for a good while and you're at a higher risk.
Hmm. So usually those who are well controlled and they have been checked out regularly, diabetes is totally fine. And what about hypertension?
I would say there's probably a cutoff there and an age situation. Like if you're over 35 and you have hypertension, like over, say, 140 systolic, contraindication. But maybe
That's
if
a
you're young.
really good. Yeah, that's the same thought process. So I'm not entirely sure of the specific number, but it is as long as it is controlled.
Got it.
So I would assume, following Hypertension Canada, looking at your age, your other comorbidities, what is a target range for you as an individual? And then as long as you are controlled, that is not an issue for COCs.
Right, so if you've got optimal drug therapy for your hypertension, you can take a
Mm-hmm.
contraceptive. But if you have
Mm-hmm.
hypertension and you've decided you're not gonna treat it and you're just gonna go about your life, probably not a good idea to throw one of these on.
Mm-hmm. That's right.
Although sort of interesting because if you then go and get pregnant, there's
Oh,
some
more hypertension.
fairly high risks to having a hypertensive pregnancy and also,
Mm-hmm.
just all the estrogen of pregnancy.
Mm-hmm.
But I
Yeah.
suppose you're gonna talk to me about other options for contraception, aren't you?
Mm-hmm. I
Okay.
am.
Okay. Let's keep
Okay.
going.
Mm-hmm. And another one, just to add on, is also liver cirrhosis or any tumors. There are, Mhm.
I was gonna say contraindication.
Yes, that's correct. So there are a few others that I'm not going to mention because they may or may not come up later, but those
Okay.
are the big ones that I think we see most often in terms of COCs and contraindications.
Perfect.
Okay, this next one. What are some potential drug interactions that can occur with hormonal contraceptives and through what mechanisms?
Ooh, hit me with the mechanisms. Okay, the only one I can think of
Hmm.
right away is, estrogen increasing thyroid binding globulin,
Hmm.
which then makes your thyroid hormone less available. So if you're on thyroid replacement therapy, you need to increase the dose.
Hmm.
That is one. Mechanism wise, I don't know how the mechanism works for lamotrigine, I
Hmm.
want to say, or kind of a few epilepsy drugs. have an interaction with birth control where they make the birth control
Hmm.
less effective, somehow I feel
Yes.
like that is related to binding of the sex steroids, but I could be wrong
Mm,
there.
So one big thing that we're concerned about is the CYP3A4. So, they mess with everything. So medications that are CYP3A4 inducers will decrease the efficacy of contraceptives.
That's where the epilepsy drugs come in.
So
Right. Okay.
antiepileptics such as phenytoin or lamotrigine, they will decrease COC's efficacy. So
Got it.
when a patient is using antiepileptics long term, it's usually recommended that they try something else that's not affected, such as an IUD, for example.
Right. Or could they use a progesterone only because the isn't it the estrogen that's CYP3A4 or is progesterone also CYP3A4?
I believe it's both. And I did a little bit of reading on that, and I believe that other methods, such as the IUS, it is less affected, which is why it's okay. But I'm pretty sure that it's both the estrogen and the progesterone, but I think
Okay.
estrogen is the main factor we're concerned about.
Right. Sorry, I'm just in my head thinking about
Hmm.
progesterone, um, thinking you're pregnant. In my mind, I thought it was just the estrogen component that was helping to make you think your body think you're pregnant. But if it is both, then you got to worry about the levels of both of them.
Hmm.
Which I
Yeah,
guess, yeah,
and
that makes sense.
mhm.
Okay, got it.
Also, yeah, and we know that there's rifampin that also has this issue. So
Right?
with rifampin, because it's usually not used very long term, sometimes it's recommended to use a backup method when you are taking rifampin and also 7 days afterwards to take that as a backup method as we reestablish coverage to inhibit ovulation.
Got it.
And there's also one uh, natural supplement that will impact estrogen and COCs. Do you know which one it is?
Just because it's on the top of my
Mhm.
head, St. John's Wort.
Yes, you're right.
Is it?
Yeah, I feel like St. John's wort is like that one thing that messes with everything and it does impact COCs.
All right. That is the only reason I got that right is because I was like, what is a natural supplement? St. John's Wort. Everybody loves it.
Right. Okay, that was very well done. Um, Moving on to our next question. What is the mechanism of action of progestin-only oral contraceptives? I kind of gave this away a little bit earlier. And add-on question, what is the time frame for when you have to take it every day? And what do you do if you miss a pill?
Oh my goodness. Okay, well, since you already answered my question, the progestin is making you think you're
Hmm.
pregnant, the high levels,
Hmm.
and it's also increasing the viscosity of your cervical mucus, which is inhibiting pregnancy that way. That's the
Hmm.
mechanism. Uh, Importance of taking it at the same time. The combined oral contraceptives are a lot less finicky than the progestin only.
Hmm.
Progestin only needs to be like to the hour at the same time every day, if I recall
Do you
correctly.
know exactly how many hours?
I'd say 3.
Oh, you're right. Good guess.
Yeah. um, yeah, you have to be pretty close. So 3 hours max difference per day.
Hmm.
And if you skip a pill, uh combined oral contraceptives, you would double up the next day, and there's a whole protocol. For the progestin only, I would probably tell people to um just take it as you would normally take it the next day and use backup for 7 days.
So very close. So we'll start from the beginning. So you're right. It does thicken the cervical mucus. It can prevent ovulation, but it's not consistent. So it doesn't rely on that. It mainly relies on thickening the cervical mucus. And it is a 3-hour window before it's considered that you're missed a pill or that you're late. However, there is one medication. The brand name is Slind. I don't remember the generic, but that one is up to 24 hours before it's
Oh,
considered missed. Yeah. So that one is an exception.
sorry, what one
And
is that? What is that one called?
Slind, Slynd.
Slynd. When did that come out?
I believe in the last year or two, I believe.
Okay, so it's a drospirenone.
Hmm. And
Is that the anti-acne one?
I believe that one is also used for acne. And I think it is the 24-hour one, which, yes. And patients sometimes prefer that one because it gives them a little bit more flexibility.
No kidding. That's great.
Hmm.
S-
Yeah,
You see what I mean? I've been out of the game for 3 years. I don't know what's going on. But that's wonderful that there's this option now.
right. Especially considering that some people who are using progestin only is it's because they can't use medication with estrogen in it. So this could help with adherence, help with efficacy. I think it's just great all around.
Yeah, that's great. And so um that flexibility comes from the drospirenone as opposed to the norethindrone
I
from
believe
the
so.
what is the brand name of that other classic one for progestin only?
For progestin only, Movies.
Progestin only pill. Micronor.
Ah, Micronor.
Micronor, which I believe became Movies as a generic.
Yeah, that one is norethindrone.
Yeah, okay, yeah. So the
That
norethindrone is the one that is you have to take it within 3 hours of taking when you would normally take it. And then so
mm-hmm,
once you've converted over to this drospirenone instead, it's that it must be something in the medicinal chemistry that allows you to have better efficacy despite changed time.
To be honest, I don't know the details on that. That's something I'm also gonna look into, but it's definitely related as all the norethindrone products, it's only 3 hours.
Right.
And this one is relatively new. So I'm excited to see what else will come out. Maybe they can extend it,
Mhm.
right?
Yeah,
And
totally. That's great.
for the last part, what do you do if you missed a pill? So it takes about 48 hours for the cervical mucus to thicken up again. So you just need a backup method for 2 days, and
2
that's it.
days. Okay. And you're not
Hmm.
doubling up. You're just
No.
2 days of backup.
Hmm.
Okay. Easy peasy.
Hmm. Okay. Next question. Assuming that a patient is otherwise healthy, how could they take a COC continuously? For how long is it safe to do so? And what is the reason for the time frame?
Ooh. I might
Hmm.
I might be coming at this with some citizen science
Okay.
versus versus what is actually correct. Okay, so I have seen many people in my day take a combined oral contraceptive continuously for
Hmm.
up to a year
Hmm.
and then go for a withdrawal period because the period you get on a combined oral contraceptive is only there in the it was only put there to make the oral contraceptives more palatable to people
Yes.
because otherwise it was thought, oh, well, I don't have my period, so I must be, this is witchcraft.
Essentially.
So I don't think there's a limit, but maybe there is a limit and I missed that.
So, oh, the first part, how would someone do that?
Oh, you
How
just
would
skip
someone take
your
it?
placebo pills.
Right. Yeah. So you just skip the placebo, go straight to the next pack. and this is usually done with the monophasic ones. As
Mm-hmm.
with the triphasic, as the progestin changes every week, it just makes it more complicated to do so. So it's usually avoided.
Yeah,
And
I used to have the triphasic ones, and I would get my 3 months at
hmm
a time, and then I would take the first week of three of them, and then the second week of three of
hmm
them, then the third week of
Oh,
three of them, which was a rather complex way to do it, but it worked.
mhm. I've never heard of anyone doing that before.
Again, citizen science coming at you.
Right. And you're right in mentioning that the period is just withdrawal bleeding. It's not, it's really just put there because when they were creating it, they thought that it would feel unnatural to women, that women wouldn't like it if there was no bleeding. So it doesn't really serve a purpose. However, it is tested to be safe up to 84 days. So it's not that it's unsafe after 84 days, it's just that it was never really tested. So it's unknown, but likely to be safe.
Okay, gotcha. So,
hmm
yeah, colloquially, if that is that the word? Um, colloquially, amongst the circles of women, people
hmm
do it for much longer than 84 days, but it's a
hmm
situation where we don't actually have adequate data to say that that's definitely safe.
Yeah, it hasn't been tested ever, but
Right.
that doesn't mean it's dangerous. It's just unknown.
Right. And I guess the main danger in my opinion, and this might be off base, is
hmm
just the risk of not noticing if things are different, right? Like if you have a withdrawal
hmm
period every 3 months, you can tell within 3 months that something is a little off. You have a way heavier flow or what have you. But if you don't have that, then maybe you just aren't being as vigilant.
Yeah, I've heard that some women, when they use it continuously, they will take a pregnancy test once a month or once every few months just for peace of mind. But there are some benefits. People do use it continuously to skip their period if it's inconvenient. There's side effects they don't like. And it is also the safest in terms of contraception. Because as we know, the first week of when you use a COC is the most dangerous, right? If you miss one pill, it's the highest likelihood of pregnancy. But if
Right.
you use it continuously, you're always in the safest fourth week, if that makes sense.
Right. I guess because you're having your period, because you're having your period, quote unquote, you're having a withdrawal bleed. It's not a very nice place for a baby to live, so you're not likely to get pregnant there. But then on your first week back after period, you could be getting into your fertile window, and the drug level hasn't quite climbed high enough.
Right. So
Got it.
it's weeks 1 to 3, you're slowly building the levels, and then you drop during the withdrawal week. But the 3 weeks of buildup is enough to sustain you through the withdrawal week, as
Right.
long as you get right back on it on week 1. And the danger is in week 1, the levels are very low. If you miss even one, then you dip below the
Mm,
level of you're safe. But if you're
right.
always using it continuously, you're constantly at the fourth week high level, where even if you miss one, you don't even really need to double up. You can just keep taking the other ones and it should be covered
Right.
as well.
Right. Which is why there's all those protocols for what happens if you miss a day,
Mm-hmm.
but you're in the first week, then you have to double up.
Mm-hmm.
Got it.
Exactly. So using it continuously puts you in the safest fourth week option always.
I love that. And you don't have to worry about
Mm-hmm.
having a period on a camping trip.
Exactly. Yeah, I actually first heard about this when I was younger because someone was saying, I'm getting married on a certain day. Could I do something about that? And I thought that was really interesting. And learning about it now from the pharmacological side, it's a very useful tool.
Absolutely.
hmm And however, there is a downside. Some people find that when they don't have a scheduled withdrawal bleeding, they may have some spotting. throughout the month. But that is usually more anecdotally. I'm not sure if it's been studied for real. But that's why some people do like to have a scheduled bleeding.
Right. Okay. Yeah, I don't know the data on that, but
Mm-hmm.
it's the whole spotting concept and how to counsel on spotting is so complicated because it relies
Mm.
on so many different factors that I've often felt sort of at a loss to explain it to people other than to say, I think we're going to have to try a different product.
Mm-hmm. Yeah, so unfortunately, birth control is one of those things that you just pick one, try it, and if it doesn't work, you switch. If it does, you're lucky. And the typical,
Mm-hmm.
what we say is the rule of 3 months. If the symptoms don't go away in 3 months, is usually when you can safely say this is not for you. But that sucks though, that you have to stick with something for 3 months, bleeding
Yeah,
for
that's a
three
long
months.
time. Even morning
Mhm.
sickness only lasts 3 months.
Yeah,
And
so
not even. It's like, it peaks at 10 weeks and then kind of goes
mhm,
down. But it's only really, really bad for 2 months. Brutal.
which
Birth
is
control can be
a
worse.
lot of time. Right. And that's just one of those things where why is that acceptable? What other medication do we say, oh, it's fine if you're suffering for 3 months, we'll readjust then,
Right.
right? So I think that just plays into how women's health is just not taken as seriously.
Mm-hmm.
But that's a whole other rant. Okay. The next question I have for you is what are some considerations for long-term Depo-Provera use, which is the medroxyprogesterone?
Ooh. Long term.
I guess don't overthink this one.
I'm getting a tickling in the back of my mind about clotting, which I know is wrong. Maybe wrong?
hmm
Maybe not wrong? Clotting. DVT? No. Okay. Give me the answer.
So it has been seen that people who use the Depo shot have a lower spinal bone mineral density than people who do not. And the effects are more drastic when it started before the age of 21 or if you've been using it for over 15 years, a long, long time.
Right.
However, bone density can improve after discontinuation almost to the original levels again. And there's no strong evidence to associate the depot shot with osteoporosis or an increased risk of fracture. So it's still a reasonable option, and there's no guidelines surrounding that so far that I've seen.
Okay. So to recap your answer, my inkling and me hesitating on it was correct because progesterone has nothing to do with clotting. That's the estrogen's
Mm,
job.
mm-hmm.
But progesterone has implications for bone mineral density. If you're
Mm,
yes?
kind of. So they've just noticed that there is this lower bone mineral density. However, there is no strong evidence to associate it with osteoporosis or fracture. So it's kind of left a little unknown at the moment.
Okay. So this was a trick question?
A little bit.
A controversial topic of discussion, if you
Hmm.
will. I'm going to pop in here and just quickly clear a few things up about this last section regarding Depo-Provera and the bone mineral density issue because it's been pointed out to me by one of my particularly smart friends who got a pre-release version of the episode that I just start talking about progesterone and not medroxyprogesterone, which is the drug we're actually talking about. And I say a couple of things that are not necessarily correct. So, progestins, which are different from progesterone, the natural hormone in your body, progestins as in medroxyprogesterone, do have some implications for clotting. So in the product monograph from Pfizer, going straight to the horse's mouth, they do talk about thromboembolic disorders and say that although Depo-Provera has not been causally associated with the induction of thrombotic or thromboembolic disorders, there have been reports of cerebrovascular and thromboembolic adverse events in obese Depo-Provera women. So before prescribing Depo-Provera, the physician should be alert to the earliest manifestations of thrombotic disorders, and should any of these occur or be suspected, the drug should be discontinued immediately. And then in their patient-specific information, they have symptoms for thrombotic disorders that they have patients look out for, and then stop the drug immediately if they occur. So that's the one thing. The other part to talk about is this issue of bone mineral density. So I started to get a little bit confused about how this would work, and I just want to walk everyone through the mechanism of it. Okay, so come with me on a journey from the hypothalamus, which is going to release gonadotropin releasing hormone. That goes to the pituitary. Then the pituitary is going to release gonadotropins, aka luteinizing hormone and follicle stimulating hormone. That goes to the ovaries, which then releases estradiol and progesterone. The estradiol and progesterone that are released by the ovaries go and negatively feedback on the hypothalamus, which is what we are taking over with our addition of medroxyprogesterone in the form of Depo-Provera. That is going to pretend that it's a progesterone. It's going to go up to the hypothalamus, suppress the gonadotropin releasing hormone, therefore suppress LH and FSH, therefore suppress estradiol and progesterone production at the level of the ovary. And that is where the bone mineral density part comes in. You have reduced estradiol produced by the ovaries, which, as we know from postmenopausal syndrome, you have less estrogen kicking around. Therefore, you get a lower bone mineral density because estrogen is super important for your bones. So that is how the bone mineral density situation arises. Hopefully that clears a few things up, and let's go back to the quiz.
Right. So I guess long-term considerations is, making sure that you don't use it for 15 plus years if you want to be on the safe side, or considering your bone health, how you're doing as an individual. But so far, no guidelines for the general patient.
Okay, cool.
Kind of a trick question.
Yeah, geez Louise.
Yeah, I've heard of stories where people say that their family doctor has been prescribing this for years and years and years, and then a pharmacist catches it, and they're like, "Hold on a moment, you're not supposed to be on this for this long." I've heard stories like that, so I thought this would be a good reminder for us that this could be something to consider.
Okay, so hold up. In the product monograph for your
hmm
progesterone only, is it a contraindication to take it for more than 15 years?
I don't believe so.
No. Okay. But it's
hmm
just kind of like a potential nuance.
hmm Yeah. Let me pull up the monograph. I believe that it doesn't list it as a contraindication, but it does say at the bottom that there has been some kind of association found, but
Okay,
not
maybe a
enough
warning.
to do anything clinically about it.
Got it. So just another thing for us pharmacists to get all worked up about and then have no real answers for anyone.
hmm Yeah, so on the monograph, under warnings and precautions, it says that since loss of bone mineral density may occur in females of childbearing potential who use Depo-Provera long term, you should do a risk-benefit assessment where you take into consideration possible benefits as well as your risks and your personal situation.
Got it. Okay.
So a
So it's a
very
warnings and
wishy-washy,
precautions.
yeah, not a good answer.
Hey, we're used to working in the gray.
That's true. We can use our clinical judgments on that one.
That's kind of the great thing about moving from being in pharmacy practice in the community to being with a toddler. I'm like, there is no gray. If it's a gray point, you're not bringing it up because then you are not a solid presence in their lives and they are going to have more anxiety. Blah
Mm.
blah blah. TikTok moms, don't at me.
Oh, yeah. Some of my friends, they have kids, and I don't know how they do it because I'm struggling just doing school, and they are somehow doing everything I'm doing, but with kids,
Oh my
and
goodness.
it blows my mind.
Yeah, no, I don't. I don't know how people go work in pharmacy all day and then come back and deal with a toddler.
Yeah, and
Not for
another
me.
thing is, yeah, like if if you fail a quiz, you do bad on a test, always another opportunity to improve. But if you mess up your kid,
Oh, thanks. Thank you.
oh,
That's
didn't
helpful.
didn't mean to add to the anxiety. That's just my thought process of how much I guess admire people and women who are mothers and want to become mothers and who do a good job at
Oh, well, shucks.
it. Hmm. Okay. Now, moving on to our next question. This one, we're moving into some postpartum questions. This may help your personal experience, but we'll see.
Maybe.
So, Priscilla is 32 years old and gave birth to a baby girl about 2 weeks ago. She is not currently having intercourse, but wants to be prepared when her and her husband become sexually active again. This was her second child, and though she loves them both very, very much, she does not want any more. She is she is currently breastfeeding, and she heard from her other mom friends about this thing called the Mirena. And she asks you, is this right for me? What should you tell her?
I would say that it's a great option, because it's not going to impact your breastfeeding.
Mm-hmm.
Um, you don't have to worry about taking a pill every day.
Mm-hmm.
It's gonna cover you for 5 years,
Mm-hmm.
up to 7, maybe even potentially at this point.
It's officially as 5, but it does, I believe it's 5. Or is it 8?
I
I
thought it
wanted to
was
check on
5, and
that
then they
too.
said, like, unofficially 7. And the
Mm-hmm.
Kyleena is 5.
I think so. There's always what they list and also what is technically
Right.
okay that they'll cover you till, and I always get those numbers mixed up. Let me.
Probably not worth knowing the unofficial numbers because then we're gonna
Mm,
counsel wrong.
mm-hmm.
But,
Yeah, so
yes, it makes sense if you're a manufacturer. You're not gonna say it lasts for 5 years and then there's a steep drop off and people get pregnant. That's not a very good way to,
yeah.
keep your business going.
Mm-hmm. I believe right now it's up to 99% effective for up to 8 years, even though it's technically listed for 5-ish years.
Wow. Okay. Quite a bit
Mm-hmm.
of residual in there.
Mm-hmm.
I like the Kyleena because it's a bit smaller and
Mm-hmm.
a bit less progesterone.
Yes.
Anecdotal, when I came off of the progesterone only IUD pre-pregnancy, my
Mm-hmm.
God, the hormonal disruption.
Oh.
Like, it's not really considered to be a systemic amount of progesterone in your body, but it took me a
Mm-hmm.
while to sort of wash that out of my system. Maybe I'm particularly
Mm-hmm.
sensitive, but it's kind of crazy pants.
Yeah. I've heard stories from my friends as well as people who come into the pharmacy how you don't realize how much it has been affecting you until you
Mhm.
get off of it. And I've also heard that people prefer the Kyleena because it's smaller. Some say it's more comfortable on insertion, but I don't think that IUS insertion and comfortable belong in the same sentence at all.
No. No. And I don't know that I don't know that you would even notice because it's 5 years different.
Yeah, I was thinking, I don't know, but some people do prefer it because of that.
All right. All right. But yeah, in terms
Hmm.
of a person who's postpartum and doesn't want to have more kids, I love it. Because even if you
Hmm.
decide at the end of the day, oh, I do actually, now that you're over the serious sleepless nights and you do decide, oh, I maybe do want another kid.
Hmm.
First of all, good luck. Secondly, it's rapid ability to get pregnant after
Hmm.
taking it out. So,
Right. Yeah, so those are some of the points I wanted to mention. Because it's progestin only, it's safe postpartum in that short window we want to be extra cautious around. It doesn't affect breastfeeding. So it says that it doesn't appear to change the quality or quantity, but there are some anecdotal, what's the word I'm looking for? Some some stories where people have said that they've noticed a decreased supply, but that hasn't been studied extensively, and it doesn't
okay.
seem to be an issue for most people.
Right.
However, the one thing that I want to draw attention to is that right now she's about 2 weeks postpartum. And for IUSs, some guidelines recommend that you wait at least 6 weeks postpartum when the uterus is fully involuted, which means it's gone back to its normal size.
Got it.
And there's also studies showing that there are higher expulsion and perforation rates if the IUS is inserted right after birth compared to if you get it at 6 weeks. But there are some practices where they will put in the IUS like hours after birth before they leave the hospital,
Yeah.
just because it's more convenient and because people tend to get back into having sex earlier than what's recommended. They want to have that safety method, but
Right.
it does have some higher risks.
Yeah. Whenever you asked that question in my head, I was thinking about, these practices where I think it's more um, women who are at risk of pregnancy, unwanted pregnancy.
Mm,
A lot of times they will put it in right away. Um, and,
mm-hmm,
um, but I could see that being risky because if your uterus isn't the size it's going to be, then
mm-hmm.
like how do you ensure that the IUS stays in the right place?
Right. And to think of it just not even really scientifically, it's like mushying, trying to get back how it used to be, and you put something in there, probably not going to be very happy.
Mhm. No.
So the answer to this question was just to make her aware of that there is a higher risk. If you want to wait a little bit longer, it's likely safer for you. And it would also depend on when she plans on being sexually active again. Right now, she's only 2 weeks postpartum and she doesn't have any plans yet. If she wants to wait until 6, okay. Well, maybe if she waits until 4, she could consider it, or she could also consider a progestin only oral pill for a short period of time. All depends on what she finds most convenient and how comfortable she is with that risk.
Right, because generally they advise you to wait 6 weeks after giving birth
Hmm.
anyway to be sexually active, but that's not
Right.
necessarily followed in the real world.
Yeah. Hmm.
Got it. Okay, so progesterone only would be a great other option to bridge you until 6 weeks.
Hmm. Hmm. But it may also be more inconvenient to be on this pill for 2 weeks and
Mhm.
then all of a sudden switch to something. I don't know. It depends on how she feels, basically.
Got it. Up to the lady.
Speaking of up to the lady, as it always should be, I think we've forgotten one option here, which is that her husband or partner or whoever would be responsible for the male sperm side of getting her pregnant when she doesn't want to be pregnant could go get a little snippy snippy. And then she doesn't have to worry about putting an IUD into her uterus that's still big and floppy like a balloon after giving birth. Maybe I'm just on my high horse about this because I am 2 years postpartum and I recall the struggle bus that was the early days postpartum. And I definitely would not have been signing up to go get an IUD. I would have been sending my husband out to go get a snippy. And then another note here, Marina, on the official monograph, it does say that it's indicated for conception control for a maximum of up to 8 years. So that is official on the monograph now.
And our next question, Jamie is picking up her Evra patch for the first time in about 2 years. She stopped using it so that her and her partner could have their first child, and she gave birth about a year ago. She is no longer breastfeeding and has had no other changes to her health. Her primary care provider agrees that going back on the patch is safe for her. She comes to pick it up and she asks if you can remind her how to use the patch. What
Oh
should you
boy.
tell her?
You put the patch on and then you put a new patch on after a week, and you
Mm-hmm.
do that 3 times, and then you skip a week, and then you do the cycle again, if I
Mm-hmm.
recall correctly, and you want backup contraception for the first week of patch use unless you are putting it on when you start your period, I think.
Mm-hmm. And what about where you should put the patch?
On the back of your arm.
Mm-hmm. Yes, that's one of the places. So you're right. It's one patch a week for 3 weeks and then 1 week off. And to make sure that you're changing your patch on the same day every week. And when you do start, okay, I'll touch on this later actually. So for the area, you want somewhere that's clean, dry, hairless, and intact, healthy skin. So no redness, irritation, cuts, etc. Some places you could put it could be on the buttock, the abdomen, upper outer arm, so this area, as well as upper torso, preferably somewhere where it won't be rubbed if you're wearing tight clothing.
Hmm.
Hmm.
Because then you get
And
more release of drug that you didn't
I'm
want?
not too sure about that. I think it may be they don't want to risk the edges coming up
Hmm.
or falling off. And they also suggest making sure that you're not wearing any makeup or creams or lotions, anything in that area, just so it stays sticky to your skin for the week.
Right.
And the interesting part that I found is about the backup method. So I was reading the product monograph and I think it's a little bit confusing. I was discussing this with one of the community pharmacists that I work with today, actually, and she agrees it's a little confusing. It mentions that you can either do a first day start, so first day of your period, or a first Sunday start, which is first Sunday after your period, but we know that's kind of bogus. It just means any other day.
Huh.
It later mentions that you should have 7 days of backup no matter which of those two options you choose. But then it also mentions that if you start on day one, you don't need backup. So it's literally just contradicting itself on the product monograph. And
Huh.
when I look at other Canadian sources, like there's a Quebec source and a Ottawa Public Health, they just say use 7 days of backup, doesn't matter when you start. I think
Yeah,
that is the safer answer with this ambiguous monograph.
I agree.
I think that it would make sense that maybe you don't need backup if you start on day one, but to be on the safe side, I think 7 days would be
Yeah.
appropriate.
I can't imagine counseling someone and saying, it's ambiguous. Don't use it. Like, no. Use backup for 7
Never.
days.
hmm Okay, and this is maybe a little bit of a tricky question. Considering that Jamie has been pregnant, had a baby, and now is having a stressful mom life, what is something that maybe the pharmacist could consider or flag when making sure that this is still effective for her?
Having a stressful mom life, potentially a weight gain, not getting as much time in for exercise could put her out of the realm of effectiveness if she
And
gains weight to a certain threshold, which I don't remember.
yeah, so that was my thinking as well. The Ever patch says that it may be less effective when the patient is over 90 kilograms. So I don't know how much Jamie weighs. Maybe this was safe for her before pregnancy, but maybe pregnancy, like it's
Right.
possible she gained some weight. We just want to make sure that this is still the best medication for her.
Yeah, good call. And the Evra patch has that warning, and so does the
Hmm.
progesterone only pills, I think.
I'm not too sure about that.
Maybe not the
I
pills.
know.
The injection?
That's possible.
1 minute later.
I don't believe so.
No?
Hmm.
I made that up? I have a tendency to do that.
There are other things where it is weight-based. For example, Plan B, it's known
Okay.
that it's not as effective. I believe it's also 90 kilograms. Yeah.
Okay.
hmm
So
Which
I just
is
got it in my
quite
head that
unfortunate.
because it's related to progesterone, that it would
It
be
could
all of
be.
them.
I'm also not an expert,
Oh,
but
come
there are
on.
definitely a few things that are associated with weight.
Okay. Evra being definitely one of them.
That's right. Okay. Next question. This one may be a little bit easier. Olivia uses the NuvaRing for contraception and uses it as prescribed. So 3 weeks on, 1 week off. She had intercourse with her partner and then they took a nap right after. When they woke up, they found the NuvaRing on the bed beside them. So she realized
Uh-oh.
that it must have fallen out either during intercourse or during their short nap. She calls the pharmacy in a panic and asks you what she should do. This is not her first cycle of using the NuvaRing, but it is week 1. And it's been about 2 hours since the beginning of intercourse.
I'm going back up 7 days. Or sorry, no, that doesn't help you. Hold up. Let me think. Okay. So she had the NuvaRing in the first week, so we're in risky business territory here.
hmm
Um, maybe do a little plan B as a just in case situation, as a plan B, if you will.
So yeah, that's kind of right. So I'm going to be a little
Oh, you're so
nitpicky
nice.
again.
That's kind of right.
It's almost right. To be very nitpicky, in the first week, the NuvaRing, the time frame is 3 hours before
Okay.
it's considered a missed pill. So, or missed medication. If she's absolutely certain that it's only been 2 hours, then technically all she has to do is rinse it off with cool or lukewarm water, reinsert it, and that's it. But if maybe their nap was longer than she thought, or it's anywhere close to 3 hours, then plan B would be an appropriate option.
Okay. So me suggesting plan B was a little bit my
Mhm.
anxiety coming out.
But to be fair, you'd always rather be safe than sorry.
Right.
So that's not necessarily a wrong answer, but it's just if they're certain it's only been a little bit of time, then it's okay. If they're not sure, then better to be safe.
Got it. Okay.
hmm
3 hours is the cutoff for NuvaRing.
In week
Missed
1.
in week 1. What about if it was week
hmm
2 or 3?
I believe it's a little longer. Let me double check that for you.
Oh, I love that you're doing my homework for me and I don't have to go do this later.
Yeah, as long as it's not too embarrassing that I'm also looking up the answers.
No, no, I think it's
Mm-hmm.
well understood that we need to look up our references. Yeah, don't worry.
I think it's still 3 hours. Hmm.
Okay.
I'm gonna double check my other source, actually. I don't trust them. I've learned to always have at least 2, 3 sources before you trust anything.
1 minute later.
Okay, so in our course that I took last year, they are saying that in weeks 2 or 3, that it's the 72-hour rule that it could be out. However, when I look on the monograph, it's still giving me a 3-hour rule.
Oh, interesting. So your professors know
Yeah,
something that the monograph doesn't.
it's possible because he has mentioned, I don't remember his exact qualifications, but he's on the board of something important, and he has given us some tidbits of things that are not on the monograph, but that we know is the truth. So
Right.
maybe he does know something we don't.
Well, I
But the
know
safe answer is
monographs tend to be rather alarmist. If you're looking
right.
at a vaginal estrogen, they'll say you absolutely have to be on a progesterone. And all of
Mm-hmm.
the professional societies are saying, no, you don't.
Mm-hmm. Yeah, I think, hmm, interesting. Ring has been out for 3 hours. Yeah, so the answer is still 3 hours.
Still 3 hours per the monograph, which is what we technically have to follow in practice. Because what you will
Mm-hmm.
find is that when you're studying in school, you'll have professors with hot takes who say, well, actually, the evidence sort of says this, blah, blah, blah.
Mm-hmm.
But if you have a patient who gets pregnant and they come to you and say, you told me that I was fine, and you say, well, it's actually
Right.
controversial. We have this information, and I heard from this person, they're going to say, you should have told me what was on the monograph, and you're going to have to defend that.
Yes. Mm-hmm. Yeah, I totally agree. So in this case, we're gonna follow 3 hours.
3 hours, plan B, if you think you're anywhere close to it.
Mm-hmm. Okay. All right. Next question. Cindy comes into the pharmacy and tells you that the condom broke when she was having intercourse with her boyfriend. This occurred about 5 days ago while they were traveling abroad. And due to being overseas and all the plane flights trying to get back, this is the first opportunity they had to seek help for this issue. She doesn't use any other contraception, and her period ended about 12 days ago. She's a little bit shaken up from the incident, and she says that she also wants a long-term option in addition to the situation right now. She prefers something long-term, convenient, and without hormones. What is something that you could recommend for her?
So sorry, I got to deal with this fire situation and then deal with the longer term.
Yes.
Okay, the fire situation. I feel like we're on the cusp of plan B not working at 5 days.
Hmm.
So I'd be taking a pregnancy test at this point and then seeing what it showed. And I'd be going
Hmm.
and double checking my references to see if we could maybe get away with a plan B. But also, it kind of depends if it was 5 days ago Canada time, like if you were coming back from
Ah,
another country, right? So
5 times 24 hours ago.
5 times 24 hours ago. I think we're on the cusp. We can maybe get away with a plan B, but check first and see if she's pregnant.
Right.
How is
So
my
plan
answer?
B, pretty good. It can be taken 5 days after. However, it does decrease efficacy. And then we're a little bit worried. We want to go see if, take a pregnancy test, see what's going on. However, there is another option that I'm hinting at,
Oh,
something that could fix the fire right now as well as the long term.
rock a copper
Something,
IUD?
yes. So this is obviously not an option for everybody, but it is a option. It is considered the most effective form of emergency contraception, and it's also the only method that will fight the fire now as well as provide coverage in
Oh.
the future. So this would work up to 7 days afterwards, and it would, work normally for up to 10 years, I believe, for the longest one, but there are some with shorter durations. So this one isn't an automatic answer for her because, of course, there's many things to consider. For example, even the heavier menstrual bleeding that many people don't want to deal with,
Right.
and also considering her anatomy, if she's had any pelvic infections, any allergies, etc. But this could be an option to consider for her.
Okay. Very
Hmm.
interesting. Yes, I had totally forgotten that copper IUDs were an emergency contraceptive. It's
Mm-hmm.
honestly not something you think of when you're at the dispensary.
Speaking of things that you don't really think about as an option for emergency contraception, you could also use a Mirena for emergency contraception for up to 5 days after unprotected intercourse. It was found in a study in the New England Journal of Medicine in 2021 to be non inferior for up to 5 days compared to the copper IUD.
Next question on this. A patient enters your community pharmacy or a community pharmacy with a prescription for mifepristone and misoprostol. There is only one pharmacist working, and they decline to process this prescription on the basis of
Mm.
conscientious objection. What are the next steps that the pharmacist should take in this situation?
Ooh, I think they have to contact another pharmacy and give that
Mm-hmm.
patient the option to get it filled there
Mm-hmm.
and let the doctor know. I don't know.
So
I've
this is a very interesting case. Do you have any more guesses?
yeah, because it's definitely a guess. Um, if there's only one pharmacist working and you're the only pharmacist in town, I don't even know that you're allowed to conscientious. I think you might have to fill it,
Mm,
is my first thought.
let's say not in town. You're in somewhere with many people. I would like to guess Victoria, but I don't know BC as well as I should.
Okay, I'm in a big city. I'm not the only
Mm-hmm.
pharmacist in town.
Mm-hmm.
I think I would say, you have to ensure that that person gets to another professional who can fill it. You can't just say, I don't want to fill it and hand it back to them.
Mm-hmm. Yeah, so that is basically the answer. I did check with the BC college as well as Ontario just to make sure that everything was the same, and it is. So, in all, it is okay to decline providing certain services on the basis of conscientious objection if you also adhere to the code of ethics. So, what that means is that you are not relying on these conscientious beliefs to discriminate against anybody, that you should also inform your employer as soon as you can of this conscientious objection so that they can figure something out. Your pharmacy should have a plan in place for what to do if this were to occur. And you do have to ensure that this patient is taken care of in a timely manner and that you are being non judgmental and non discriminatory. So,
Right.
all that to say,
So
mhm.
if you're the only pharmacist on duty at that point, that doesn't necessarily mean you're a one person shop. You could say, come back in the morning. My colleague will fill this for you.
So that could be an option. However, something that would work better is you know in advance that you have a conscientious objection. You have spoken to the pharmacy across the street, and and you know that they can dispense this. So, in a more timely manner, is you
Got
could
it.
call them. Do you have one? Yes. Hold that aside. I'm sending someone over right now. So that would be the easiest and fastest way to solve this issue.
Got it. Okay.
So all that blab just to say you can have your beliefs as long as you're objective and you find a solution for the patient, all good.
Okay. Good
hmm
to know.
Okay. So this is our second last question. This one has quite a bit of information if you want to jot them down as I go, or I could also remind you.
Okay.
So
Walk me through it.
Abby Abby is a 28-year-old woman, and she is looking to start a method of contraception as her and her partner don't want to use condoms anymore. She is about 5'10" and weighs 95 kilograms. She doesn't smoke, but she does socially drink 1 to 3 glasses of wine on the weekends. She is currently engaged and getting married this winter, so about 6 months from now, and they plan on starting a family right away after the wedding. She would be diligent and follow all instructions of any medications you suggest. She takes zolmitriptan for migraines with
Oh my
aura.
goodness.
She
This is
takes
a
5 milligrams. She takes 5 milligrams at the onset and may repeat in 2 hours. And also, she takes ibuprofen, 200 milligrams once daily, when needed for some knee pain from an accident a few years ago. Which of the following would be the most appropriate option for her?
oh my goodness.
Number 1, the Depo-Provera shot, the Mirena IUS, Alisena, and Movies.
Okay, I'm getting rid of the IUS right away because it's expensive.
Mm-hmm.
She's already got wedding costs and she wants to get pregnant immediately after the wedding.
Mm-hmm. Okay, so Mirena is out.
Mirena is out. Sorry, what was her... Describe the patient again?
Mm-hmm. So shortened version, 5'10", 95 kilograms, socially drinks, and wants to be pregnant in 6 months. Oh, zolmitriptan for migraines with aura, and ibuprofen PRN.
And what are my other 3 drugs?
You have Movies, Alisena, and Depo-Provera.
I'm going Movies because Alisena, it'll take a while to get pregnant after you discontinue. And Depo-Provera, there's probably some issue with your zolmitriptan or weight or something.
You have them right, but switch the other way around, actually. So we'll go through the options. First of all, the Depo shot. Each one lasts about 12 to 13 weeks.
Oh,
So
right.
she
Okay.
could get 2 and make up that 6 months. However, it can take up to 1 to 2 years to get menses back, whereas she wants a baby in 6 months. So not a great option for her.
Right.
Secondly, the Mirena. She only wants contraception for the next 6 months. I don't know why we would want to put her through insertion and getting it back out if it's only for 6 months.
Yeah.
Alisena, because there is the estrogen in there, it's a contraindication for migraines with aura. So we're getting rid of that
that's
one.
where you're coming from with the zolmitriptan.
Mm-hmm.
Aha!
Yes. And the Movies, the last one, it's okay for her migraine. And it is very easy to stop. And though there is a stricter 3-hour time frame, she says she's chill with that. She can follow whatever. So in this case, it
Right.
would be the best option for her.
Okay. So the details I didn't have totally correct, but it was Movies is the answer.
Mm-hmm.
Okay. Got
Yay.
it. Yay!
Yeah, as long as you get to the right answer, that's all that matters.
That's what counts. C's get
Yeah, that
degrees,
one.
but they also start a podcast 3 years later because they forget what they studied.
So this question, I did try to throw in some things that are unrelated just to try to fool you.
Oh, good.
So
I look
five
forward
foot
to it.
10 makes no difference. 95 kilograms makes no difference. Socially drinks makes no difference. Ibuprofen for knee pain, PRN makes no difference.
Those were red herrings.
I was trying to get you.
Ah, well, you did multiple times on this quiz, so.
Okay, now this is the last question I have for you. This one could be a little tricky. Might help to write some times down.
Okay.
So Mary got her depot shot about 12 weeks ago for the first time. But now she wants to switch to the Kyleena just due to the adverse effects, and she just didn't like the depot shot. Today is Monday, and she is getting her Kyleena inserted this afternoon. She was supposed to get her next depot shot on Wednesday, 2 days from now, as that is 12 weeks exactly since her last one. Her doctor told her that she needs to get the shot every 12 weeks to maintain coverage, but she also heard that you need a backup method when you first use Kyleena. So she's worried about maintaining coverage as she switches from one to the other. What should you tell her?
I would tell her, because I've been reading the test paper for other clues for this question, that you actually are covered for 14 weeks with the Depo-Provera. And so she should be fine.
You're right. So the depot shot, though they recommend 12 weeks, it's actually effective for up to 13,
Oh,
possibly
okay.
even
I
longer,
misquoted the
but
test paper,
13.
aka Cheen-Young.
Yeah, I mean, potentially longer, but they will say 13 to be on the safe side. So, Hyleena, you do need 7 days of backup when you first start it. So, 7 days will bring her to next Monday, whereas 13 weeks will bring her to next Wednesday. So, technically,
Mm,
she's completely covered and she has a 2 day buffer. And even though we always like to be better safe than sorry, in this case, I think 2 days is plenty of time and she doesn't need to worry about it.
okay. And that's like on the monograph technically covers for up to 13 weeks? Okay. So
Yes.
I'm also covered legally.
Yes, that's correct.
We're not just saying he said, she said. My professor is a very smart man or woman.
Yeah.
Got it.
hmm
Okay.
They like to say 12, so just in case you make your appointment a
Right.
little bit late, you're still all good.
Okay. Cool. And I mean, also, even if I'm counseling that, yes, you need a backup, I don't know that I'd say, here, pay for another Depo-Provera. I just say, use some condoms
Yeah.
if you're willing.
hmm
Got
Right.
it. Got it. Was that my last
So,
question?
yes, it was. What did you think of the
Wow.
quiz?
I loved it. I loved the breadth of what you covered.
Mm.
And I feel like it was a really great reminder of all the things that I used to know, or maybe didn't necessarily know, but now I do. What was
hmm
also interesting for me is being a student, you learn a certain amount of things really, really well, but there are certain things that I didn't
hmm
necessarily focus on. And so having it taught to me by a student who gets into the nitty gritty was really helpful. So yeah, get
I'm
all your friends to come on the podcast, and or you could come back. Would be great.
Uh-huh. Yeah, I'm so glad you enjoyed the quiz. Because you mentioned you want it to be PBC-esque. So I was
Mm-hmm.
thinking, like, I've never written the PBCs. What do I do? And all the sample questions I've Googled were not very good. Maybe I
No.
just haven't paid for the good ones, but I haven't seen anything really good. So my approach to the questions was just looking at the prevalence that we see things and try to allocate the amount of questions accordingly and also try to throw in a few real life situations that I've heard of when I worked in the
Mm-hmm.
pharmacy, hoping to give it a more practical, real life perspective.
No, I think that was great. I think this is going to be a perfect first episode to throw out there. Um,
Mm.
and it will serve as a model for the other students to follow. So that was
Oh,
great.
that's great.
Yeah.
Did you have
Well,
a favorite or least favorite question?
uh, honestly, I mean, classic me, just like in school, I've forgotten everything we covered already. So no, no. I did like the patient questions. A little tough for me to figure out what, to like really look at them because I'm
Mm,
doing it in audio style and I was afraid to do
right.
too much I didn't want to type because it might screw up the
Mhm.
audio. So they were kind of tough, but they were also very interesting because that's actually what we do as pharmacists is, you
Mhm.
know, work through multiple different factors, and having you to ask questions. Oh, but what's the deal with the weight? Oh, what medication are they on? As a reminder, actually kind of modeled, having a mentor in the pharmacy space. So, um, I did really like them, but I'm glad that you didn't just start with those because we covered
Mhm.
some basics, and then I could kind of pull on those. Basically,
Right.
you covered the basics at the top and reminded me things that are important that then helped with the later questions. So, yeah,
Mhm.
that was great.
Yeah, I'm glad you liked it.
Thank you so much for coming on.
Of course, I had such a good time.
Well, it was great to have you. I look forward to having you back to maybe talk about HRT.
Yeah, that'll be great. Until next time, Kimberly.
All right. Bye.
Bye.